But I just want to check. Can you hear us at St. Paul's? Just want to wave. Somebody, can you see them waving? Yeah, great. Good, good. Okay, 7:30, sharp-ish. David, this is what time do we start? It's West Coast, so we don't start exactly at 7:30. Anyways, it's a great pleasure to introduce David Cherney. So David is an associate professor of medicine at the University of Toronto, UHN, and did his training in Toronto, and actually is one of the few nephrologists in the country who's a physiologist as well as a nephrologist, and has done a lot of work in human physiology, understanding renal transport and various other things, and as a consequence has actually helped us with our understanding of SGLT-2 inhibitors and other transport mechanisms specifically focused on diabetes. He's well funded from JDRF, CIHR, is a Crescent graduate, which is one of the first places that I met him, and is also funded by Heart and Stroke. He's been a driving force in Canadian nephrology and understanding mechanisms and best treatments for people with diabetes type 1 and type 2, and he's going to tell us all about what we need to know in 2020. So welcome.
Thanks, Adira, and thanks to everyone here and also off-site. I'm going to use the laptop to point, so hopefully the folks off-site can see that too. So these are my disclosures in this area. I work very sort of in a non-focused way with all the different companies in this area that make various therapies for type 2 diabetes and have trials that are ongoing, both operating grants and investigator-initiated studies. So in terms of objectives, we're going to go through two main areas today. One is the SGLT-2 inhibitor story, and we'll talk about mechanisms, and we'll talk about some of the cardiovascular safety and efficacy trials. And Dira asked me to focus on mechanisms and not just to list a bunch of trials. So we will go through what's necessary to understand the scope and the depth of what's currently available, but we'll also talk about the why. Why do these therapies potentially have their effects, especially in the kidney? And then talk about some ongoing studies in that area, and then at the end discuss the GLP-1 receptor agonists, because that's probably where a lot of us are going to be moving next in terms of protection against cardiovascular and kidney disease. So this is sort of why we're all here, I suppose, which is a slide that's meant to illustrate the fact that we have not made a ton of progress in terms of reducing the risk of end-stage kidney disease in people with diabetes and indeed overall over the last 20, 30 years. And in contrast, in people with diabetes, there has been, as you can see at the top here, there have been these very nice reductions in the risk of acute myocardial infarction and stroke, probably because of both better interventions, but also better medical therapies that our cardiology colleagues have studied in depth in large numbers of patients. Whereas at the bottom, you can see in blue that end-stage kidney disease risk has really stayed quite flat over the last 2 to 3 decades. And there was even newer data from last year by the same group that showed that these risks are potentially even increasing over time. So it shows how much work we have to do in this field to reduce risk of progression over time. Which brings us to new therapies, including SGLT-2 inhibitors. And so I don't know how many of you have used these therapies, how familiar you are with them, et cetera. But essentially they're agents that work at the level of the kidney, and they do so by blocking sodium and glucose cotransport through this pathway, which is the SGLT-2. These agents primarily act on SGLT-2, and by blocking this transporter, that essentially leads to a glucosuric effect, because glucose is no longer reabsorbed through the proximal tubule cell back into the blood. And so as a consequence, that leads to glucosuria. So A1C typically goes down by about 0.7%, and there's also a bit of a weight loss effect of around 2 to 3 kilograms. There's also a natriuretic effect, which is what we're actually going to focus on a little bit more today. The natriuresis is important because of its links with blood pressure lowering, as well as effects on reducing heart failure hospitalization risk because of the natriuresis, and also reducing kidney risk over time as well through mechanisms that I'll describe very shortly. So I want to explain why these agents have their interesting effects in the kidney, especially for us, why they reduce proteinuria. And they've been shown to reduce proteinuria by around 30 to 50% on top of an ACE inhibitor or ARB. So let's talk about why that might be. And these effects happen quite quickly. So if you are using these therapies, you'll probably see that albumin to creatinine ratio or 24-hour urine measures decrease pretty quickly by about 1 to 2 weeks. And that's probably because of a hemodynamic effect that these drugs exert, at least in people with diabetes. So if we start with normal physiology on this slide and just sort of start on the left-hand side of the panel, if you develop volume contraction or a reduction in sodium delivery to the kidney because of hypotension or illness, then that reduction in blood flow to the glomerulus, and this happens in people with and without diabetes, that reduction in blood flow decreases these little blue dots, which are meant to depict sodium. So there's a reduction in sodium delivery to the kidney, and hence a reduction in sodium delivery to the little salt sensing area that we all have called the macula densa. So if there's less salt delivery to the macula densa, move to the right-hand side over here, less salt will get reabsorbed through the macula densa cells because less is being delivered. And as a consequence of that, less ATP is burned in order to reabsorb that sodium. So under those conditions, less ATP is broken down to adenosine, which is the metabolic waste of ATP breakdown. And ATP in this area is a vasoconstrictor. So if there's less vasoconstriction at the afferent arteriole where this is happening primarily, then the afferent arteriole will dilate. So less vasoconstrictor, the afferent arteriole dilates, and that's good because under conditions of a reduction in blood flow, that keeps renal perfusion constant and avoids a significant fluctuation in GFR. So basically protects us in an autoregulatory manner from developing acute kidney injury. So that's tubuloglomerular feedback, and that's in part because of these ATP and adenosine-related pathways. And I'll show you more about that afterwards experimentally to demonstrate and prove what I'm saying. So this is important under conditions of diabetes as well, because of course patients with diabetes aren't hypotensive, they're generally hypertensive about 70% of the time. But under conditions of hyperglycemia, these SGLT-2 transport mechanisms become hyperactive. So there's much more sodium and glucose co-transport proximally, and as a consequence of that, less gets delivered to the macula densa, which you can see on the right-hand side. So if it's all being reabsorbed upstream, less gets delivered downstream to the macula densa, and the afferent arteriole kind of gets tricked into thinking that there's a state of hypotension or volume depletion, when in fact the sodium is just being reabsorbed at upstream segments of the nephron. Nevertheless, the afferent arteriole dilates, and this raises blood flow and raises GFR, and contributes to this intraglomerular hypertension, hyperperfusion state that's characteristic of early diabetes and has been linked with kidney disease progression and albuminuria. So the idea with the SGLT-2 inhibitors from a mechanistic and hemodynamic perspective is that by blocking these transport mechanisms proximally, you can see all the little blue dots of sodium being delivered to the macula densa now. That leads to an increase in sodium delivery at the level of the macula densa, which causes ATP to be broken down to adenosine. The adenosine acts at the adenosine 1 receptor, and that causes the afferent arteriole to constrict back to normal diameter so that there is a reduction in glomerular hypertension and proteinuria. And these effects happen very, very acutely, as I'll show you in a moment. And this is because of normal autoregulatory responses that we all have, regardless of diabetes status. Okay, so that's tubuloglomerular feedback, afferent constriction, and the effects that these drugs are thought to have. It's kind of like an ACE inhibitor effect, but it's through the inflow afferent side rather than the efferent side primarily. So in animals, we've known for some time that there is an effect on reducing hyperfiltration, and that may be one of the protective mechanisms that these drugs have. But it's only with advances in technology experimentally that we can actually visualize these changes. This work was done by Kengo Kido Koro's group and Naoki Kashihara in Japan. And you can see that they're able to both measure single nephron GFR and also measure the diameter of individual afferent arterioles. So they basically are able to anesthetize an animal. There's a high-powered microscope that sits on the cortex and can focus in on individual cortical nephrons and see what happens to those nephrons before and after a maneuver, like giving an SGLT-2 inhibitor. So you can see on the left-hand side that exactly what you'd expect happens. This is single nephron GFR before and then after medication, and you can see that single nephron GFR is decreasing by about 28% or so in response to empagliflozin, one of the SGLT-2 inhibitors. Then you can see on the right-hand side that in response to the SGLT-2 inhibitor, that the diameter of the afferent arteriole is also decreasing significantly. So they can measure the same afferent arteriole in the same animal before drug and then after drug. So it's not like they're measuring different afferent arterioles. It's the same one before and after that's sitting under this microscope. So you're probably asking what that looks like, and this is what that looks like. So this is a really pretty image of an individual glomerulus. That's what the G stands for. So this is a glomerulus. The efferent arteriole is over here, and the afferent arteriole, which is this big dilated floppy afferent arteriole, is dilated at baseline because of this tubuloglomerular feedback mechanism that I mentioned to you. These are animals with type 1 diabetes, so they have very high GFRs, and that's in part because the afferent arteriole is too dilated. That's before drug, and then after drug, you can see very nicely, at least on my screen I can see very nicely, that the afferent arterial diameter has decreased, so it's constricted, and this is after only 2 hours. So I suspect if it had been measured earlier than that, the same thing would have been shown at an even earlier time point, but the protocol was to do it at 2 hours. And so even at 2 hours, let alone a day or a month or a year, there is this afferent constriction that's been shown in these animals with type 1 diabetes. I think what's perhaps so important about this series of studies is not just showing the afferent constriction, because we sort of have been able to impute that from a whole host of previous experimental studies. What's so important about this series of experiments is that they went on to then block adenosine to prove that adenosine is required to cause that afferent change in tone. So what you can see here is that these are the untreated diabetic animals. They have a high GFR compared to the control animals, so that's just because of the afferent dilation, which we've discussed. You give an SGLT-2 inhibitor, the GFR goes down because of the afferent constriction. And then if you give an SGLT-2 inhibitor with a pharmacological medication that blocks adenosine, what happens? The GFR goes from this relatively normal level because of the constricted afferent arteriole right back to untreated levels. In other words, the animal treated with EMPA and an adenosine blocker has the same GFR as an untreated animal. So if you block adenosine, the SGLT-2 inhibitors have no effect on renal hemodynamic function. You have to have this signaling cascade intact in order for these drugs to have their effect. So what do we know in humans? So in humans, we, of course, can't do in vivo microscopy with anesthesia, so we have to do indirect measures of kidney function. So this is a study that we did about 5-6 years ago, which showed that just like in animals, we see this effect on GFR. This is total GFR measured by inulin, where GFR goes down significantly by about 20% in response to empagliflozin in patients with type 1 diabetes and hyperfiltration, regardless of what their blood sugar levels are. We did these studies during euglycemia and hyperglycemia, and the effects were the same. Their blood flow also decreased, and their renal vascular resistance rose. So a reduction in blood flow in GFR with a rise in renal vascular resistance is very much in keeping with an afferent constrictive effect, in line with what was shown in these more recent animal studies. We even measured adenosine levels in the urine of these patients and showed that in people with type 1 diabetes, especially during hyperglycemia, that urine adenosine levels increased. We don't have a medicine that can block adenosine like we can do in animals, so we have to rely on these indirect measures of adenosine physiology in humans to correlate the responses with what's been observed in animals. So very similar observations in summary in animals and in humans, which seems to imply that adenosine is required for these changes in kidney function. More recently, this group in Holland showed that there are similar effects in people with type 2 diabetes. So this is a group of patients with a mean GFR of around 80 or 90 at baseline, and they were studied during U and hyperglycemia, and you can see at in the top panel that just like in people with type 1 diabetes, there's a reduction in GFR, not as much, but still a reduction over 12 weeks. And similarly, you can see that renal blood flow tended to decrease as well, although those changes weren't statistically significant. So very similar effects in type 1 and type 2 in the sense of reductions in blood flow and GFR, which suggest afferent constriction. So far I've said that the SGLT-2 inhibitors appear to induce an afferent constrictive effect that reduces glomerular hypertension, hyperfiltration in animal models and in people with type 1 diabetes and possibly type 2 diabetes. And that's, of course, in contrast with what we've been doing for the last couple of decades around the use of ACE inhibitors and ARBs, which are thought to act primarily at the efferent arteriole, but also reduce glomerular hypertension just by dilating the efferent arteriole. And so in the studies that I'll mention to you in the coming slides, patients, especially in Credence, which is the kidney protection trial, were all in a background of an ACE or ARB, and then the SGLT-2 inhibitor was added on top of that, and that's where the additional benefit was seen. So it's on top of standard of care. So that's the hemodynamic kind of lens of how these therapies work. I don't want to give you the impression that that's all there is to know in this area. There is definitely more that's going on here. There's a whole literature around improving oxygenation with the SGLT-2 inhibitors. There's a literature that's evolving around suppressing inflammation and fibrosis with the SGLT-2 inhibitors. This is one example of in vitro studies whereby exposing human proximal tubular cells to high glucose levels increases the levels of this interleukin 6, and then if the cells are then treated with an SGLT-2 inhibitor, so basically you stop the glucose from getting into the cell to cause all the toxic badness, then that suppresses interleukin 6 levels in this experimental model of hyperglycemia in the kidney. You can see that interleukin 6 levels decrease with SGLT-2 inhibition. And similarly in humans, as has been known in animals, and I'm just not showing you that data because of time, in humans with type 2 diabetes, interleukin 6 levels tend to decrease with dapagliflozin. They've been shown to reduce with canagliflozin. So there probably is an effect on suppressing levels of inflammatory markers, at least in blood, and whether that has clinical relevance to kidney or cardiovascular protection, we don't know, but this is a story that's still evolving. So there are hemodynamic mechanisms, there are effects on inflammation, and there are probably other pathways that are important for how these drugs work at the level of the heart and the kidney to reduce risk over time. So regardless of the mechanism, 6 years ago now, there was the first study that was published that looked at the effect of these agents long-term was published. That's the EMPA-REG Outcome trial. That was in patients with established atherosclerotic cardiovascular disease, and showed that there was about a 14% reduction in major adverse cardiac events, so non-fatal MI, non-fatal stroke, cardiovascular death. And there were also reductions in mortality and reductions in heart failure hospitalization as well. So I won't go through that in more detail because these are renal rounds, but from a renal perspective, there was also this significant 39% reduction in the risk of incident or worsening nephropathy. So progression of albuminuria, doubling of creatinine, dialysis or transplant, or renal death. These are important clinical outcomes that were significantly reduced in terms of the risk of those outcomes. They were significantly reduced in people with type 2 diabetes. And importantly, one of the, I think, critical observations that was made from EMPA-REG Outcome was that this was a cardiovascular safety study. So this was not meant to reduce glucose levels in these patients. And as a consequence, the effect on glycemic lowering by design of the trial was really very modest. So there was less than a 0.4% reduction in the two arms of the active treatment groups. So in the low-dose EMPA group, A1C went down by about 0.24%, so a very, very tiny amount. And in the higher 25 milligram dose group, it was about 0.36%. So very small reductions in A1C and yet very substantive cardiorenal protective effects in this trial. So we went on to then look at a cohort that had been included, so 7,000 people, and we wanted to know what is the effect of this therapy, not just on hard endpoints, but what happens to kidney function decline over time, what happens to albuminuria. And so we looked at patients according to baseline risk in the EMPA-REG Outcome cohort, in patients with normal albuminuria at baseline, microalbuminuria at baseline, or macroalbuminuria at baseline, which is how we tend to group a lot of our patients when we see them in clinic. And what we showed was that in addition to this expected dip in GFR, so all patients have this dip in GFR in the three groups, this initial little dip is just because of this afferent constriction, which reduces glomerular hypertension and induces a hemodynamic effect. And there are really nice similar graphs from IDNT and Renal and other older kidney protective trials with ARBs that show an identical pattern with this initial dip in GFR, which you expect with an ACE inhibitor or ARB, and we also should now expect with an SGLT-2 inhibitor because of the hemodynamics and the mechanisms through which these drugs act. But after that initial dip in GFR, GFR tends to return back toward baseline, and by the end of the trial in patients with normal albuminuria, there wasn't much of a separation, only a couple of mils, which perhaps you'd expect because these patients are pretty low risk at baseline. Still a 12% reduction in albuminuria at the end of the trial in patients with normal albuminuria. In patients with microalbuminuria, again, a very little separation of the GFR curves over time at 3 years, but a big effect on albuminuria, about 40% reduction. And where you really see the benefit is in patients at high risk, those individuals with macroalbuminuria. So after that dip in GFR, so GFR goes from 66 down to about 61, 62, and then very slowly declines. By the end of the trial, patients had lost about 10 mils over about 3 years. But in contrast, in people treated with placebo, they also started at 66 and then ended up somewhere at around 46 at the end of the trial. So they lost about twice the amount of kidney function over a relatively short period of time, very much in line with what we then saw in the Credence trial, which I'll show you afterwards. So big preservation of kidney function and a reduction in albuminuria, again on top of an ACE inhibitor or ARB. We also went on to then look at, well, what are interactions with these therapies and other drugs that also influence hemodynamics? I'm not going to go through all the data with you just because of time, but in a subsequent analysis that was published in KI, we looked at the effect of whether you're on an SGLT-2 inhibitor with an ARB or ACE inhibitor. Does that affect the dip in GFR? Does that affect the benefits that these drugs have? If you're on an NSAID or a diuretic, that also can influence volume status and changes in kidney function, or a calcium channel blocker, which can also impact on renal hemodynamics and on blood pressure and other factors that control renal function over time. Regardless of the background therapy, NSAID, ACE inhibitor, ACE ARB, diuretic, that little dip in GFR that we saw is the same across those different groups. And the other important message is that there was no difference in terms of the renal benefits. So there was no heterogeneity of the signal. In other words, whether or not you were on any of those other background therapies, the benefits around those composite renal endpoints were the same. I'm not advocating using NSAIDs. NSAIDs are poisons. You shouldn't use NSAIDs. But the patients on an NSAID, you shouldn't expect to see anything different in terms of their effect on GFR initially, at least in an EMPA-REG outcome-like cohort. So I think it's an important message for us to know as nephrologists. The other very important message that subsequently came out, and Mark Cooper published this, and this is just a brief report in American Journal of Kidney Disease. It's such an interesting observation and so important for us in practice, which is to say that it doesn't matter what your A1C is at baseline. So at the top here you can see if your A1C is 7 to 8, 8 to 9, greater than 9, doesn't matter. The benefit at the end of the trial was the same in terms of renal protection. So you don't have to worry if the A1C is 7 or less than 7. Still start the SGLT-2 inhibitor because there's still kidney benefit regardless of the glucose. And similarly, they did this even probably more important analysis around the change, which is to say if you have a big reduction or a small reduction in your A1C, it doesn't matter. There was still benefit in terms of kidney protection. So we don't have to be so worried about the A1C baseline or change with these therapies. There is still a benefit around kidney protection, which shows us more and more that the effects of these therapies are independent of glucose and glucose lowering as well. From a mechanism perspective, this was perhaps most nicely shown in this kind of analysis. This is from previous phase 3 studies that looked at the A1C change and the blood pressure reduction. So not only are there differences, are there preservation effects around kidney protection regardless of A1C, you can see that in patients with lower kidney function, so as GFR goes from stage 1 to 2 to 3 to 4 CKD, there's very little A1C reduction. And we know that because as GFR declines, there's very little filtration of glucose. So you wouldn't expect the A1C to go down very much. And yet, these drugs still have benefits not only on cardiorenal outcomes, as I showed you in the previous slide, but they also have reductions on some of the factors that we mentioned, that we monitor and follow, like blood pressure. So there's still a nice blood pressure lowering effect, for example, as you go from stage 1 to 2 to 3 to 4. If anything, the systolic blood pressure lowering effect is accentuated. And that's been shown with other agents, like in analyses with dapagliflozin. So the effect clinically is preserved on blood pressure, albuminuria, and is also preserved in terms of preventing hard renal endpoints, even in patients with impaired kidney function, even though A1C does not change very much. So we have to start putting A1C to the side a little bit in terms of thinking about how these drugs work. Similarly, this is an analysis with ertugliflozin, so a drug that's very similar to empagliflozin in terms of its pharmacological characteristics. What we see with ertugliflozin is compared to an active comparator, so either glimepiride or metformin, the effect of these therapies is still present, even though there's no glucose-lowering difference between, ertugliflozin and glimepiride, for example. What you still see on the right-hand side is that albuminuria decreases by about 30 to 40%. Even though glucose lowering is the same between the two groups, there's still a greater reduction in albuminuria, even when you compare it to an active treatment, another glucose-lowering therapy. So those are some data from EMPA-REG Outcome and a little bit of supportive data to highlight that these effects are independent of glucose lowering. I want to also highlight that there are other trials that have looked at kidney protection with these therapies, including CANVAS and DECLARE. So I just want to show you one slide on each trial. And CANVAS was an interesting study in that it was also a higher cardiovascular risk cohort, so about 2/3 of patients had established atherosclerosis at baseline, and also showed a reduction in MACE, so major adverse cardiac events, and also showed renal benefits, especially around reductions in albuminuria of around 27%, and a reduction in this composite, which didn't even include albuminuria. So if you just look at 40% decline in GFR, requirement for dialysis or a transplant or kidney or renal death, there was still a reduction of around 40% in the CANVAS cohort. So very similar to EMPA-REG Outcome. The difference, of course, in these trials was the safety signal. And when this trial was published in around 2016, there was a lot of concern around the increased risk of fracture and amputation in this trial, which had not been shown in EMPA-REG Outcome and was also not shown in DECLARE or in CREDENCE subsequently. So this is the only trial that showed this risk. I'm not going to pretend to understand why one trial showed this risk and the others didn't, but we can certainly talk about that afterwards if you'd like. So DECLARE was the final cardiovascular safety study that's been published. Also showed a reduction in one of their primary composites, so cardiovascular death or hospitalization for heart failure, which you can see at the top over here, which was reduced by 17%. This is all driven by a reduction in heart failure hospitalization, and they also had a 47% reduction in their renal composite, which was a greater than 40% decrease in GFR, end-stage renal disease, or death from renal causes. I think what's so important about DECLARE, and to call it out specifically, is that it was the lowest risk cohort. So only about 40% of people in this cohort had established cardiovascular disease. Their GFR at baseline was 85, so probably not even patients who we would see. And less than a third had micro or macroalbuminuria. Most of them had microalbuminuria. So a huge cohort, 17,000 people, and because of that, they're able to look at these kinds of effects on endpoints like this. And even in that low-risk cohort, there was a significant and very substantial reduction in a hard renal endpoint. And just do take note, this doesn't even include albuminuria progression. So this is just the 40% decline in GFR, renal replacement therapy, or death from renal causes. So what's subsequently emerged from these trials, from the EMPA-REG Outcome, Canvas, and DECLARE studies, is a bit of a surprising signal around who benefits the most from these therapies. And so this is a meta-analysis that came out almost simultaneously with DECLARE. This is patients with GFRs of less than 60 in 3 trials, 60 to 90, and greater than 90. And the hazard ratio was actually the lowest for patients who were the most healthy, the greater than 90 group, suggesting that the magnitude of the effect, and this is statistically lower than the GFR less than 60 group. So this hazard ratio of 0.44 is different statistically than the hazard ratio of 0.67. There's statistically more benefit around renal endpoints in patients with GFRs of greater than 90. So you might expect the opposite, that people who were the sickest have the most to benefit and therefore have the lowest hazard ratio. And based on this very large data set, it appears to be the opposite, that the benefits may be the greatest in people who have the highest GFRs at baseline. Again, interesting food for thought. So after the completion and publication of these 3 trials, so EMPA-REG Outcome, Canvas, and DECLARE with empagliflozin, canagliflozin, and dapagliflozin respectively, was the first kidney primary endpoint trial, which is CREDENCE, which is published at the World Congress meeting in April of 2019. And this trial was and is unique in the sense that it included people only with type 2 diabetes, patients with GFRs between 30 and 90, who had macroalbuminuria, so the UACR cutoff in our units was about 33, and they had to be on an ACE or ARB for more than 4 weeks before getting into the trial. And they were randomized to the low dose of canagliflozin, which is 100 milligrams a day, or placebo, and then followed for the requisite number of endpoints that was required as part of the trial. So this was the primary endpoint slide, which you can see included end-stage kidney disease, doubling of creatinine, renal or cardiovascular death, which was significantly reduced by 30% with canagliflozin versus placebo, which was highly statistically significant. Lots of events. And if any of you were taking care of the patients who were in CREDENCE, I know that you had CREDENCE patients here, as did we, at Toronto General Hospital. These were really sick patients. So baseline GFR of around 56, a lot of comorbid cardiovascular disease, heart failure, albuminuria, and they had a lot of events during the trial. In addition to a reduction in the primary endpoint, there was also a reduction in CV death or hospitalization for heart failure. This is the same endpoint that was reduced in DECLARE. And again, all driven in DECLARE by heart failure. Also, a 20% reduction in MACE, a reduction in hospitalization for heart failure, and a reduction in end-stage kidney disease, doubling of creatinine, or kidney death. So again, major kidney and cardiovascular benefits in CREDENCE, very much aligned with what was seen in the previous trials that I've reviewed already. I also just want to highlight this slide, and I don't want you to necessarily see this, I just want you to see the pattern. Okay, so it's sort of like a Rorschach test. And you can see that this is meant to illustrate that glucose doesn't matter. So this is published by Chris Cannon in Circulation about 2 months ago, and shows that if you walk down this line, this is sort of the path that I want you to walk, none of these hazard ratios are different in terms of high A1C versus low A1C. So the primary endpoint and all the secondary endpoints, there's no difference according to patients with an A1C of less than 7, 7 to 8, 8 to 9, etc. It didn't matter. The benefits were all the same. So we don't have to worry about, even in a CREDENCE-like cohort, what the A1C is at baseline or what it's changing by. That's not something we have to follow from a renal protection perspective or from a cardiovascular protection perspective. It just doesn't matter. The benefits are still there, even if A1C is relatively controlled or doesn't change very much. Okay, and I think it's an important message for those of us who aren't necessarily have a practice that's set up to deal with a lot of glucose lowering. I think that's an important message for us to think about. So credence was, of course, very important in terms of changing practice and practice guidelines. And this is from the website of the National Kidney Foundation, which was put up once the FDA-approved Canagliflozin as a kidney protective therapy, and similar changes are occurring in Canada as well. So I've spent a lot of time talking about the non-glucose effects of these therapies. There's a lot of interest in thinking about these therapies in terms of their effects in patients who aren't hyperglycemic. This is an illustration of the DIAMOND trial, which we completed recently, including with Dr. Barber and Dr. Levin and sites in Holland and Malaysia. And we studied 50 people with non-diabetic kidney disease and randomized them to dapagliflozin or placebo, and then crossed them over to wherever they weren't on the first place. The primary endpoint was proteinuria, and so that is under review now, so we'll hopefully be able to show that data soon. But the idea is that it shouldn't matter what the ambient glucose levels are in terms of the physiological effects of these therapies, and we'll see whether that plays out in small studies like this or in larger trials that are evaluating those therapies in people without diabetes. In people with type 1 diabetes, there does seem to be a strong rationale also for the use of these therapies, and we've looked at sotagliflozin and empagliflozin in people with type 1 diabetes, and showed that just like in people with type 2 diabetes, we get this typical dip in GFR, return back toward baseline, and then stability over time. So this is sotagliflozin, which is actually approved for use in type 1 diabetes in Europe, but not anywhere else in the world yet. And similarly, at least initially, sotagliflozin also reduced albuminuria by about 30% in people with type 1 diabetes. Small cohort, only a couple of hundred people, but still showed a significant and similar trend to what's seen in people with type 2. So there seems to be very similar effects in type 1 versus type 2 in terms of the renal potential benefits of these therapies in these individuals. There are trials that are much larger than these small analyses that I've showed you in terms of elucidating the effects in people who have other causes of kidney disease aside from type 2 diabetes. So I've told you about credence. There's also the DAPA-CKD trial, which is ongoing in people with type 2 diabetes and nephropathy, or who have nephropathy not from type 2 diabetes. IgA nephropathy, various GNs, hypertensive, nephrosclerosis, etc. And that study is still ongoing, but will also answer this question around non-diabetic kidney disease. And then Adira and I are also leading in Canada the EMPA-Kidney trial, which also includes people with and without diabetic kidney disease. And the most innovative, I think, part of EMPA-Kidney is that if the GFR is on the lower end, so between 20 and 45, you don't even have to have albuminuria, which is important because, you know, IDNT, Renal, credence, DAPA-CKD, they all required inclusion of patients with albuminuria. So we actually don't know if these therapies benefit people who don't have albuminuria, and EMPA-Kidney will at least in part answer that question in patients who have GFRs in the lower range. So a really important trial. Do remember that these therapies are diuretics and natriuretic therapies, so they should be on your list of sick day medicines to stop when patients have a flu or a cough, or they're not eating or drinking, or they're hospitalized, or they're getting a contrast study, or they're getting an operation. These drugs should be held while patients are in those situations and then reinitiated afterwards, just like you would a diuretic or an ACE inhibitor. Okay, so that's the SGLT-2 part of the talk. The last couple of minutes, I wanted to also mention the GLP-1 receptor agonists, because they are also equally fascinating. We just know a lot less about the GLP-1 receptor agonists. So let's review a little bit around what's known about these therapies. So the GLP-1 receptor agonists are also in sort of similarity or alignment with the SGLT-2 inhibitors. They were used initially as just, you know, glucose-lowering therapies. They're very good glucose-lowering therapies, and they act through a variety of mechanisms as part of the incretin class. But what was noted in a lot of the cardiovascular safety studies is that beyond the effects on glucose lowering, they also seem to have interesting effects on the kidney. So especially in people with kidney disease and GFRs between 30 and 60, you can see from the LEADER trial with liraglutide that over the 36-month period of treatment, people treated with liraglutide seemed to have better preservation of kidney function versus those treated with placebo. This was a statistically significant difference in terms of GFR preservation over time. And what I also want you to notice is that these drugs are not hemodynamically active. So in contrast with the SGLT2s, they don't cause this little dip in GFR. So you don't have to worry about these changes in kidney function that you do have to follow with the SGLT2 inhibitors. So they work through probably a different mechanism than the SGLT2s. They don't have this ACE inhibitor reduction in hyperfiltration thing that the SGLT2s exert. But similar to the SGLT2 inhibitors, they also reduce albuminuria. They probably reduce albuminuria. This is probably on the higher end. So this is with lixisenatide, and Daniel Rauch's group published this post hoc analysis showing that in patients with macroalbuminuria, there was a 40% reduction in patients treated with lixisenatide. That's on the very high end. I think that most of the data with the GLP-1 receptor agonists would suggest more of a 20% reduction in albuminuria over time in people with albuminuria at baseline. But whatever the exact number, there is an effect on albuminuria lowering in addition to these preliminary observations around preserving kidney function. So how do the GLP-1 receptor agonists work? So I could stand here and wave my hands for the next half an hour and go through a bunch of animal data, but I don't think either of us would be any farther ahead. The answer is we don't know. Okay, so there are lots of hypotheses. People talk about inflammation, reducing oxidative stress in blue. There's some experimental data to show that. There's also some experimental data showing the reductions in nuclear factor kappa B, suppression of cytokines, impact on various cell adhesion molecules that preserve renal architecture in response to ambient hyperglycemia. Whatever the mechanism is, it's not hemodynamic. There is a bit of a blood pressure lowering effect, but no renal hemodynamic effect. And all of these mechanisms may then converge to reduce inflammation, fibrosis, and albuminuria, but without having this ACE inhibitor hemodynamic effect. So it seems that it's quite different than the SGLT2s. These drugs are, so far, primarily studied, and they've been noted to have cardiovascular protective effects, especially in high-risk groups. So this is a meta-analysis of various cardiovascular safety studies, ELIXA, LEADER, SUSTAIN, EXCEL, HARMONY, etc. And in people with baseline atherosclerosis, you can see that there is about a 20% reduction in the risk of subsequent atherosclerosis-related cardiovascular events of MACE. Interestingly, if you don't have atherosclerosis at baseline, there doesn't seem to be any protective effects with these agents. So cardiovascular protection in high-risk patients. What's emerged from a renal side is that when examined in terms of progression of kidney disease in these cardiovascular safety studies that I just mentioned, that there also seems to be a benefit around the kidney. So I've mentioned a reduction in GFR slope from LEADER, and I also mentioned there's a reduction in albuminuria. That's true, and in the LEADER trial, they also had a renal composite, which is a secondary endpoint, and you can see that there was about a 22% reduction in this composite endpoint, which was progression of albuminuria, doubling of creatinine, renal replacement therapy, or renal death. Same old renal endpoint that was used in the SGLT2 studies. But what's very different here is that in LEADER and in SUSTAIN-6, which is used another GLP-1 receptor agonist called semaglutide, this benefit on this composite endpoint was all driven by a reduction in albuminuria. So there was no change in terms of, or no difference in terms of doubling of creatinine. There was no change or difference in terms of renal replacement therapy. So in contrast with the SGLT2s, where there's a very clear signal and a very clear benefit based on existing data that not only is albuminuria benefited, but also doubling of creatinine is reduced, also dialysis, also dialysis or transplantation. With the GLP-1 receptor agonist, that is not the case. So far, based on existing data, it's really just an anti-albuminuric effect that's been shown. Perhaps the caveat to that, or the exception to that, is the AWARD-7 trial, which was a smaller study in about 600 patients. I love how, we haven't had large trials in nephrology for years and years and years, and here I am standing here calling a 600-patient kidney disease trial a small trial. So it's not a small trial, but it's smaller compared to the large renal endpoint and cardiovascular endpoint trial. So I don't mean to put that down. I'm just saying it's smaller and exploratory. In AWARD-7 with dulaglutide, which is really important because they didn't use a placebo, they compared dulaglutide, another GLP-1 receptor agonist, to insulin. So they just took the whole glucose lowering effects thing out of the whole equation because A1C change was identical. If you take insulin or a GLP-1, the glucose lowering effect was the same. And what you can see in this slide is that patients treated with insulin glargine, they lost about 3 mils over a year. So these are patients with CKD stage 3 and 4. They lost quite a bit of kidney function. In contrast, if you were treated with dulaglutide, the high dose, you lost only 1 mil. So you actually save about 1 to 2 mils per minute per year in this analysis of about 600 patients if you use a GLP-1 and not insulin, suggesting that there is a benefit around protecting kidney function in higher risk patients that could be clinically relevant. And similarly, in the REWIND trial, which is another GLP-1 receptor agonist study with dulaglutide, same agent, this was published by Herzl Gerstein's group about 1.5 years ago or so, and they went back into the REWIND cohort, which is a large cohort of people with a mixture of cardiovascular risk at baseline, and they showed that if you were treated with dulaglutide, that you had a tendency toward having less of a reduction in GFR of 30% and a 30% reduction of having a sustained reduction of 40% in GFR and a 44% reduction in having a sustained reduction of 50% decline in GFR. So it seems like more and more, based on AWARD and based on REWIND, that there seems to be an emerging literature in patients with kidney disease who are treated with GLP-1 receptor agonists that there is some effect on preserving kidney function with these therapies. Ultimately, we'll only know if the GLP-1 receptor agonists are kidney protective with the completion of dedicated trials. And so the FLOW trial with semaglutide, which is probably the most robust in terms of the metabolic effects, semaglutide is being looked at as a kidney protective therapy in the dedicated FLOW trial in people with albuminuria and impaired kidney function to look at whether these non-hemodynamic effects of these therapies actually translate into benefits on hard kidney endpoints. So we've talked about the two sort of front runners in terms of kidney protection, the SGLT-2 inhibitors and the GLP-1 receptor agonists. And this body of work in this literature, these trials, is translating into changes in practice. So this is the American Diabetes standard of care in terms of complications that was published about 1 year ago or so. And you can see that this is a difference compared to previous guidelines in that in people with established cardiovascular disease or kidney disease, then have to think about, does atherosclerosis dominate? So if you have a history of a heart attack or a stroke, for example, or peripheral vascular disease, there's really some equipoise about whether you should use a GLP-1 or an SGLT-2 inhibitor because the trials have shown benefits in all of those patients with both therapies. And you can use your clinical judgment to use a GLP-1 or an SGLT-2 inhibitor. In contrast, however, for us, if kidney disease predominates, or for our cardiology colleagues, if heart failure predominates, you really should be looking for a reason not to start an SGLT-2 inhibitor. So if they have albuminuria, if they have heart failure with reduced ejection fraction, all of the data to date would suggest that the SGLT-2 inhibitors are the preferential drug to use next. In contrast, if patients can't use an SGLT-2 inhibitor, then in that case you can fall back to a GLP-1 receptor agonist because there are still benefits with those therapies in patients with heart failure or kidney disease. So I'm going to end there, and we have about 10 minutes for questions. My conclusions are that The SGLT-2 inhibitors do have their effects in the kidney that we've discussed that are largely, if not completely, independent of A1C, which is good for a nephrology practice or a cardiology practice. Credence showed a reduction of 30% in the primary renal endpoint. I also want to leave you with the sort of thought for the future, which is that there is the potential for kidney protection with other agents that act through other mechanisms, especially inflammation and fibrosis. We talked about the GLP-1 receptor agonists, but there are lots of other agents that we'll talk about maybe in the next rounds, mineralocorticoid receptor antagonists, the ASK1 modulators. So there are lots of other therapies that are targeting inflammation that may or may not be beneficial. We'll know when the studies are done, but could be used in tandem and in conjunction with the therapies that are now standard of care. So I'll just want to acknowledge my collaborators, including some members of the audience we've worked with, especially on the DIAMOND trial, and I'll look forward to your questions, including from here and also from off-site. So thanks for your attention. Should we go off-site first or on-site? Yeah. Hey, Matt. How are you?
Good, thanks. Thank you very much for your talk. It's really great to go over this. I am coming at this from a little bit of a specific perspective, that is in the context of kidney transplantation. I know you've done some work with Sunita Singh on this, and there's some studies ongoing, but from a physiological perspective, with a denervated kidney, single kidney physiology, also some renal afferent vasoconstriction with cyclosporin and tacrolimus, what do you think the proposed effect would be with SGLT-2 inhibitors in that context?
Yeah, that's a great question, and one that Sunita and I have given a great deal of thought to. So there is one study with EMPA that focused on basically just safety in 50 people with renal transplantation and showed safety. So there were expected effects on A1C and weight. So it seems that even in the setting of a denervated kidney, there is still an effect on glucose lowering and weight, which you'd perhaps anticipate. Maybe the bigger question that you're getting at is, what's the effect more broadly from a cardiorenal perspective in terms of protection in people with kidney transplant? So we don't know yet. We published some very preliminary pilot data in 10 people just showing basically apparent safety with Canagliflozin. We have a heart and stroke grant, which is hopefully going to get off the ground in the coming months, looking at some of the mechanisms that you're mentioning. So direct measures of GFR and blood flow. We're going to do echo, endothelial function, arterial stiffness, and some measures of the sympathetic nervous system, including heart rate variability and circulating markers of the sympathetic nervous system. So we don't know yet, but what I would anticipate is probably doesn't matter if the kidney is denervated. And the reason I say that is that there is quite a bit of evidence in humans and some in animals showing that, if anything, SGLT-2 inhibitors suppress the sympathetic nervous system. So there's experimental work showing inhibition of tyrosine hydroxylase, the rate-limiting step in the production of adrenaline and noradrenaline, and that might be what accounts for the neutral heart rate change with SGLT2s despite plasma volume contraction. You'd expect heart rate to go up, and it doesn't. And it may be that there's an effect on suppressing the SNS. So in a patient with a denervated kidney, they have like the ultimate suppressed SNS in the kidney. They have no SNS in the kidney. So I would expect there to be very little difference physiologically, because I think a lot of the mechanisms are independent of SNS. But that's a great point, and I look forward to completing that study to answer that more definitively.
Initially, I thought there were descriptions of SGLT-2 inhibitors affecting RAS, with RAS inhibition.
Yep.
You didn't mention that, so is that completely out of the picture? And then secondly, could you comment on, I mean, not that it would be a likely scenario, but on someone that you can't use RAS inhibition, the benefit we might get with an SGLT-2 inhibitor. Anyway, we don't have those studies.
Sure. Great questions. Thanks for bringing them up. So in terms of the RAS story, there is, so in our type 1 cohort that I showed, the SNS does get activated, but very, very modestly. So as an example, just to put it in quantitative terms, so aldosterone was measured in our cohort and went from about 25 to about 40. So what's a normal aldosterone level in someone who's not diabetic? It's somewhere around 200 or something like that. It's quite elevated. So people with diabetes typically have this very suppressed circulating levels of the RAS. And so what happens when you transiently and modestly contract plasma volume is that the RAS does get a little activated, but it's in a very suppressed range. So it does go up statistically. I don't think it's of any clinical importance, though, in terms of the levels of the RAS markers that we see. And people with type 2 diabetes tends to also go up, but again, in a very suppressed range. I think what's maybe more interesting is at the tissue level, what happens to the RAS. And there is a really nice paper published in the American Journal of Nephrology about a year ago or so in a non-diabetic animal model of kidney disease. And in the animal model, it's the opposite. So the RAS in tissue in the kidney tends to get suppressed. So, and that actually doesn't surprise me all that much, because in kidney disease, of course, there is this discrepancy between circulating levels of the RAS and tissue RAS. So it probably is happening exactly as you'd expect. Blood levels go up a little. That's because of plasma volume contraction. And in tissue, you're suppressing bad things and neurohormonal activation. And so tissue RAS goes down a little bit. So that's what's known. In terms of the effect in people who don't have a RAS blocker, so the only way to really answer that question is based on these sort of funny-looking sensitivity analyses from these trials. And so they look at people, you know, who were or who were not on an ACE inhibitor in these various trials, and there weren't a lot of them proportionately, but the numbers are actually quite big, because the numbers now, we're up to like 45,000 of people who have been in cardiovascular safety studies. The bottom line is that there's no heterogeneity. If you're on or off an ACE inhibitor, the effect on cardiovascular or kidney endpoints is the same. But there aren't dedicated trials, for example, to look at large numbers of people with macroalbuminuria who can't take an ACE or ARB, and we have lots of patients in our practices like that. Does the SGLT-2 inhibitor have still a benefit in a credence-like cohort? And 99.9% of people in credence were on an ACE or ARB. So we can't really answer that question well, but based on existing data, it seems that there's no heterogeneity. Right, so there were lower proportions of people. So in DAPA-CKD and in EMPA-Kidney, it's recommended to be on ACE or ARB. You have to have a reason not to be on it, but we will have lots of people who are not on an ACE or ARB in those trials, but they're still ongoing, so we just don't know. But so we will have that data eventually. I think there's a question in the back of the room. Yes. Yes. No, Smith, okay. Go ahead. Yes, sorry.
Okay. Is there any experimental lab data on what actually happens with urinary sodium excretion? Because distal to the macula densa, if there's a persistent natriuresis, there are some subsequent changes that take place. So you talked about the initial volume depletion, but is it sustained? Is there actually sustained changes in ECF volume? Is there changes in downstream sodium absorption? And what are those physiological changes?
Yeah. So what's interesting about these therapies as a diuretic is that in contrast with the effect of a thiazide, where the effect on plasma volume contraction is quite transient, as you know, it only lasts for about 8 weeks or something like that with the thiazide, and then plasma volume returns back toward baseline, and there are a bunch of studies from the 70s and 80s showing that. So the blood pressure lowering with the thiazide is not from plasma volume contraction, it's from vasodilation and other things. In contrast with the SGLT2s, the best study that was done in this area was by Guido Heerspink in around 2013 in Diabetes, Obesity, Metabolism. And he showed that compared to a placebo and thiazide, dapagliflozin induced the typical reduction in plasma volume. And then at 12 weeks, what you saw was that the thiazide went right back to baseline again, just like those studies from the 70s and 80s, whereas the dapagliflozin group still had a persistent 7% reduction in plasma volume. So it seems to still persist over time. And supportive data for that is if you measure serum albumin or or hematocrit, what happens, interestingly, is that hematocrit goes up by about 5%, and so does albumin, and that happens very quickly within about a week or two. And then if you measure hematocrit or albumin after years of therapy, guess what? It stays elevated. So there's this interesting persistent hemoconcentration effect that happens, which is in line with these observations of direct plasma volume contraction. So it seems, based on available data, that there is a persistent contraction of plasma volume, which may be important for keeping people out of hospital for heart failure, for example. For the natriuresis, what happens is that there is a transient natriuresis, so the 24-hour urine sodium, as an example, goes up for about 3 days and then goes right back to where it was at baseline. So what probably happens is there's this rapid natriuresis the establishment of a new steady state with a lower plasma volume, and then just resets and stays at that level over time. In terms of distal tubular delivery, which I think was the last part of your question, fractional excretion of sodium increases immediately. It happens within a single dose, and we've shown that. Fractional excretion of sodium over time is a little more controversial. Some data has shown a persistent increase in fractional excretion. Some data has not shown that change. So it's not really known what happens over time in terms of the fractional excretion. I'm still agnostic about that. We need bigger numbers to really look at that. And there is a study called DAPA-SALT, which is ongoing, looking at salt intake, volume, and salt excretion over time, and that'll answer your question.
Just coming out of time, but just any questions on the remote sites? St. Paul's or Mill Jubilee?
So many sites.
So many sites and people on the phone. I guess partingly, insulin's probably a lot worse for people with type 2 diabetes than we ever imagined, and I've heard endocrinologists say it's probably the worst thing that we ever thought of, not for type 1s, but especially for type 2s, and perhaps some of the data that you showed with the sodium retention that we also know occurs with insulin, never mind the weight gains, it might be becoming less and less used in type 2 diabetes.
Absolutely.
Thoughts about that?
And I think that's one of the reasons why the AWARD-7 trial is so important, is showing, like, in a patient who we would treat, patient with CKD stage 3-4 who has albuminuria, what does a GLP-1, which is an alternative, do versus insulin? So the patients treated with the GLP-1 had way less hypoglycemia. I see tons of hypoglycemia, I'm sure you do too. They had way less weight gain. They had better kidney function preservation, and they had less albuminuria. So that's a pretty good profile compared to insulin, which does the opposite of all those things. So I totally agree with you, and I think we will be using a lot more GLP-1s, regardless of what flow shows. I think we'll be using a lot more GLP-1s to avoid all of those downsides of insulin, which I agree is that if we can avoid insulin, we should be avoiding insulin. I totally agree with you. Great, thank you. Thank you.